Hi, welcome. My name is Brad Rasky, for those of you who don't know me. I'm your medical director here at MedCare, and we want to take a look at the year of 2015 and a couple things that we had changed and looking ahead to the year 2016. First, I wanted to thank everybody for all their hard work here at MedCare. You guys have been doing a great job. I've been hearing excellent things, so keep up the good work, and let's move on to our update here. So we made quite a few protocol changes this year, and I just wanted to touch base on a couple of them here. First, we've really reduced the use of backboards. So as you know, the literature really hasn't supported routine use of backboards, and actually it's been shown a lot of problems with backboards. These include people having decubitus ulcers with as little as 20 minutes on a backboard. It also provides restriction of breathing and ventilation, so there's respiratory issues, and as you all know, the risk of aspiration is higher on backboards. Therefore, we've made reflections to that in the protocol. You still can use them if the specific situation needs, or if the sending facility or physician desires and mandates a backboard. Other than that, really their use nowadays is for extrication and scene management. But again, there's isolated cases, so if you have to, feel free, but we're really trying to minimize it due to all the different problems associated with routine backboard use. And this is supported by a position statement that has been issued by the Central Ohio Trauma System, as well as the majority of other Central Ohio hospitals, and that has been provided in your protocols for you to review and as a reference. The next thing I want to talk about is the addition of dextrose. So we have been carrying the D50 amps, but now we are also carrying the bags of dextrose at 10% concentration. What you'll notice is it should be stocked in every bag. And the reason we're doing this is evidence has really started to shift, saying that this is a little bit better management for our hypoglycemic patients. It provides a couple different benefits. So it's less concentrated, which provides less damage to the veins when it's infused. We also will gain familiarity, because this is the preferred solution concentration for pediatric patients as well. So for an adult, when you have acute hypoglycemia, whether they're unresponsive or responsive, you start the infusion. And if they're unresponsive and they find a sugar less than 60, you infuse the entire 250 milliliters as a single bolus. For the majority of patients, this will bring their sugars up and not actually have to overshoot like we commonly see in D50 or D25 concentrations. And for pediatric patients, use your protocol dosing there. It's about 4 to 5 milliliters per kilogram as a bolus for hypoglycemia for under 60 as well. So we'd really encourage you to use that. Let us know our feedback. It's also, additionally a cheaper medication, and D50 was on shortage for a while. So a lot of other agencies have had good success with this, and I'd like to see us move to this in the future. So we're just going to show you a little bit of a video here on dextrose. And like I said, the standard dose for an adult is just give 250 milliliters as a one-time bolus. You can repeat as necessary, but this really helps with avoiding hyperglycemia in these difficult to control patients. And this can be given IV or IO. We've been hard at work here. It's been a year since the major Ebola outbreak in Africa. And so we continue to look at our bags, our Ebola readiness kits that we've deployed. We're also working and putting together a training video and PowerPoint for people to use and be familiar with, so you'll see that coming out here in a little bit. But we've been working hard. We've done joint training with area hospitals on live simulation of transport of Ebola patient. Luckily, the outbreak is becoming to be managed a little bit better, and we're seeing very few cases that are new coming out of Africa. And many of you as paramedics will know that we've deployed new ventilatory devices. So the new vents are in. They seem to be much more user-friendly, so please make sure that you're accustomed to it, and in your core competencies we'll be making sure that everybody's familiar with the new vents in their management. So 2016, where we're headed. So I want to devise a little bit more specific transport protocols for our inter-facility transports. First, we're going to have a ventilatory and sedation management to really optimize the care for our intubated patients, because in the long transfers we have issues with sedation and oxygenation. So I want to make sure that we're all up to date and providing the best care. And we're also going to look at devising a little bit more specific stroke care in specific patients who have received TPA and their transport, because this is a hot focus and a very difficult patient population to maintain. We're going to talk about a couple new medications, fentanyl and labetalol, that we're adding to our formulary, and some guidelines. So the American Heart Association no longer routinely recommends post-cardiac arrest cooling. So when we used to put ice packs in the groins and axillary regions, we no longer are routinely recommending that, and so you'll see that reflected in 2016's protocol changes. So more specifically, looking at the cardiovascular emergency interfacility transports, looking at it from the scene-based, we want to make sure that we have quick identification. So make sure that you're familiar with the Cincinnati pre-hospital algorithm. There's many other algorithms, but the Cincinnati and the Cincinnati Plus algorithm seems to be the best used and most reliable. When you're at the scene, you're really the eyes and ears of the emergency department, so it's important to really get some information that will really help us in the management back in the emergency department. So knowing the last known well. And this is a commonly misunderstood term. It's really the last time that the patient has been seen normal, if the patient knows that they were normal. For example, if you have a patient who awoke with the symptoms of left-sided arm and leg droop, you ask when they were last normal. If it was when they went to bed last night, that is your last normal time, and that should be reported. It's not the time of 7 a.m. that they woke up. Also, really try to gather how they knew they were normal or not normal, or what their symptoms were. This really helps your hospital providers know exactly and determine how they knew they were last normal. So if they knew that they were working on their keyboard and their left arm stopped working, that's a very clear indication we have a very specific time. If they're a little bit more vague about it, that gives us some information as well. And also know about if they've had previous strokes, what side deficit they have, and if there's any residual. And also the one important key differentiator is, did they have a hemorrhagic stroke? So ask these important questions. Also, are they on any anticoagulants? These are very, very popular. I feel like almost 20% of the patient population is now on it, so make sure we ask them what type. As far as guidelines for stroke care, really the indications for TPA are up to 4.5 hours. This is in certain specific situations. Otherwise, within 3 hours is your typical time frame. There's additional studies, such as the Wake Up Stroke study that they're doing, trying to look at patients who have had the stroke sometime during their sleep. So it's important, regardless of the time frame, to get these patients to the right place at the right time. Now, specifically looking at the patients who have received TPA or have already been diagnosed with a stroke, our blood pressure guidelines really want a blood pressure of less than 185 over 110. And this is for an ischemic stroke. And in particular, these are the criteria for TPA administration. And in regards to this, we're going to add a new medication, labetalol, to manage that, and we'll talk about that a little bit later. We want to make sure that the blood pressure is below 185 over 110, but we have to make sure that we don't drop the blood pressure too low, because when we decrease the blood flow to the brain, the surrounding tissue, known as the penumbra, actually can undergo further damage. Our guidelines also don't want us to reduce the blood pressure more than 20%. As far as a hemorrhagic stroke goes, these guidelines state that the blood pressure should be less than 160 over 100. And so the ideal blood pressure is really between 120 and 130 in these people. It's very important when you're transporting a patient to identify the patient as a stroke alert to the receiving hospital on your ENCODE. This really helps them identify that this is a true stroke patient, as opposed to another patient who may be weak and dizzy or have some non-specific neurologic findings. That way the team can be all clear what to expect and what the treatment has been given. En route, make sure that you monitor for the complications of TPA. Obviously, the main complication we worry about is bleeding. So it's important to frequently reassess their vital signs, their GCS, and their neurologic changes. And this should be documented with vitals every 10 minutes. Ideally, we should be doing about every 15-minute neuro checks. So just document that the symptoms haven't changed, or if they have, note why. obviously increase your concern if they have worsening sleepiness, worsening speech, swallowing difficulty, or one-sided weakness that seems to worsen. These are indications that there potentially could be a new bleed due to the TPA that had been administered. And the rate of this severe complication is just less than 10%, which is actually a pretty significant amount when you look at all the people who have received TPA. So the blood pressure control, I had mentioned this before. You can do this with several different methods. You can do it with nitroglycerin. Nitro paste can sometimes be used. But the new medication we're going to add here is labetalol. So labetalol is a beta blocker medication. And it actually is a real nice medication to use in stroke, as it is pretty quick in onset and doesn't last more than an hour or so. So you may have to redose this for those longer transport times. The initial dose should be 10 milligrams, and this is given as a slow push over 1 to 2 minutes. The effect actually should be seen by about 10 to 15 minutes. So repeat the vitals in 10 minutes. If you see no improvement in the blood pressure, then it's indicated to go ahead and give a second dose of labetalol at a dose between 10 to 20 milligrams. Again, if your 10 milligrams didn't do much, maybe the 20 milligrams is a more appropriate dose. But be careful you don't lower their blood pressure too much. The goal, remember, for an ischemic stroke is less than 185 systolic or less than 110 diastolic, preferably both. The complications from labetalol, as it's a beta blocker, is low heart rate. So this should not be indicated for anybody with a heart rate less than 60. The next protocol I'd like to talk about is the care of the mechanically ventilated patient. So there's really kind of two separate sides to the story. One, the actual vent management, which everybody's pretty familiar with, and we'll outline that a little bit clearer in the protocol. But what I wanted to touch on here today is actually the management with medications of the sedation level of the patient. And typically when we get a patient that's transferred, a lot of times they're on propofol. And this is pretty good in the hospital when the patient's not being moved. But when they start getting moved and bumps on the roads, they get a little bit more agitated, and as you're aware, a lot of times have difficulty breathing or over-breathing the vent, or bucking the vent even, as it's commonly termed. So what we'd like to do is we're going to clearly outline the use of Versed for these types of patients, as well as adding in fentanyl to help with the acute management of this. And we'd also like to have people be able to titrate the propofol. And so these are a couple things that we're going to talk about right here. So you can use Versed, and the dose is 0.05 milligrams per kilogram. And really what that equals out to in the average person is roughly about 5 milligrams. And this should probably be your standard dosing for an average 70-pound male. For the lighter weight and geriatric patients, I would drop that down to between 2 and 4 milligrams and just see how they do with that. The max dose on this will be 10 milligrams that you can give on a single dose. In addition, and at the same time, but in a separate syringe, you can draw up fentanyl. We have this now added, and that's going to be a dose of 50 micrograms to 150 micrograms as your standard dosing. And this one's a little bit easier to figure out. It's 1 microgram per kilo. So the average person is going to receive between 70 and 100. And remember, these are intubated patients, and as long as their blood pressure is stable, overshooting is okay. So I'd probably start with a standard dose of 100 micrograms of fentanyl for these patients. Remember, our goal is to have them sedated and to be able to tolerate the vent appropriately. The number one cause for patients being agitated and moving around and not tolerating the vent is actually pain. So really fentanyl should probably be your first go-to, in addition to the propofol drip that they're most likely on. In addition, we're going to start opening it up and allow us to titrate the propofol. And most hospitals usually start at a dose of 15 micrograms per kilo per minute. The dose you can actually start lower at 5, so you can back that down if you need, if blood pressure requires it. And remember, when you have the ventilated patient, we expect close monitoring and documenting the vitals, since blood pressure does become an issue with the high dose of sedatives that they typically receive. And this next slide here is the Richmond Agitation Sedation Score. It's called RASS for short. And this is something that really helps with your documentation when you're doing your vitals, to actually just add in the RASS score. So if you look here, really our goal is a RASS level between -1 and -3. So it starts at 0, and that's a normal, alert, and calm person. As you get agitated, you enter the positive numbers, and as you're more sedate, you enter the negative numbers. And so really a score of -1 to 3 is really what our goal would be. So -1 is drowsy, they're not fully alert. -2 is light sedation, so that means you can wake them up and they kind of open their eyes, but then quickly drift off to sleep within about 10 seconds or less. And then a -3 is really when they will open their eyes to stronger stimuli, but then will go immediately back to sleep. And this kind of helps you gauge and as well as document what our sedation patients should be looking like and acting like. So I want to highlight fentanyl here since that is a new medication for us. So as you know, it's a narcotic medication. The benefits of this is that it's a relatively short-acting medication, so it's short in onset, short in duration, and it's an ideal drug to use in our trauma patients as well as the sedation patients when you need to get some quick management of that. So like I said, the dose is 1 microgram per kilo for an average person. So that roughly is between 75 micrograms and 100 micrograms. But obviously with our heavier patients, 150 micrograms is your maximum dose. You should be administering this slowly over a minute or two, as if you give it too quickly, it can cause what's called a rigid chest syndrome. And this is when the muscles of the chest wall kind of start to spasm, and then you get some ventilatory issues. And so that's why you don't want to push it too rapidly. You can repeat this dose as needed at a frequency of every 10 minutes. This can be given IV, IO, or intranasally. Remember, if you give it intranasally, split the dose in half and give half in each nares. Obviously, we can see some lowering of the blood pressure with this, but it's usually fairly minimal. But there are a subset of patients who can lower their blood pressure quite quickly. So just be sure to monitor this quickly. And then it does cause respiratory depression, as any narcotic medication can do. Your reversal agent, Narcan, can be used for this. Also, fluid boluses can be given for lowering of the blood pressure. Versed is another medication that can be given to the intubated and sedated patient. These can be given alone or in combination with the fentanyl. And your dose here, the standard dose is really between 5 and 10 milligrams. It is weight-based if you want to, and it's 0.1 milligrams per kilogram. Again, this will cause sedation, which is the whole point of the medication. It does lower the blood pressure a little bit more than fentanyl, but not as much as other medications, and a lot less than propofol will. So this is a medication you're already familiar with since it is in our protocol. And I want to lastly touch on propofol. So propofol is technically in the class of general anesthetics, and this is a medication that through the state of Ohio we cannot initiate, but we can maintain. And as part of our ongoing training for this, we're providing that here, and we'll provide it in written form as well for you to understand this medication and that you can titrate it out. And so the typical dose that will be started is anywhere between 5 micrograms per kilogram per minute or up to 50. Most hospitals will not go above 50. And so a good starting dose is usually 15 micrograms, as what your patient might already be on. You can lower it in increments between 5 and 10 micrograms every 5 to 10 minutes. And so this will help you give appropriate sedation to that patient. But if it's a patient who just becomes acutely agitated and has otherwise been fine on it, that's really when the push dose sedatives and pain medications such as fentanyl and Versed are best used. So really changing the propofol is kind of our last line in the 3 efforts to keep the patient appropriately sedated. Propofol does cause hypotension, can cause bradycardia. It is nice because it's fairly quick in onset, and sedation is very effective with this medication. And this is a change in the rate, but we do not give bolus of propofol for these patients. And that concludes our 2015-2016 kind of wrap up and look ahead. I appreciate your time and reviewing this video. Thanks again for all your hard work this year. Looking forward to another great year. We've got some good stuff ahead of us. And so please feel free to contact me if you have any questions, concerns, suggestions. I'm here to help you and to maximize the care of our patient. And my email address is bratsky@medcareohio.org.